Hi everybody, I'm Dr. Deed Harrison, President of CBP Seminars and Technique and President of Chiropractic Biophysics Nonprofit, our spine research foundation. If you've been following these weekly or somewhat weekly videos, you know that what I'm doing is I'm going through each one of our CBP Nonprofit research publications in a video review on YouTube. And the reason is I know not everybody has time to download and read a full text article, and also they can be quite expensive to access the full text. I've taken a couple months off just for some personal time, and I know many of you have asked me to do these videos, and so this week we're going to launch out a brand new publication that's actually a pre-press publication. You can access the abstract and the full text paper on the Archives of Physical Medicine and Rehabilitation on their website under in-press articles, but it is not yet in PubMed. It will be once this pre-press article gets edited and copy and typeset. However, the Archives of Physical Medicine and Rehabilitation put this article out early as a pre-press study, and you can access it online. For example, I purchased my own paper through the Archives of Physical Medicine. I went to their website, I located the study, and I paid for and printed out the pre-press study. This is the addition of a sagittal cervical posture corrective orthotic device, aka the Denarol, to a multimodal rehabilitation program improves short and long-term outcomes in patients with discogenic cervical radiculopathy. That's the title. This is a new randomized trial that was just accepted in the Archives of Physical Medicine. Now this journal, if you don't know, it is really the premier physical medicine and rehab journal in the world. So what a huge honor for my colleagues and I to be published in this journal and to have our project found worthy. My co-authors are Professor Ibrahim Mustafa, Professor Aliyah Diab, Assistant Professor Shima Taha, and myself, Deed Harrison. Now, my colleagues and lead authors are from Cairo University in Egypt. We've been collaborating on several projects, and this is really the first to hit the press and hit a top peer-reviewed journal. We have several more in the works and several more that are actually in press. We're going to go through this particular project, and again, you can access the full text article and all the figures that I'm not going to go through because those are in the actual paper, but I will go through some verbal text with you, but I'll defer you to the actual figures that are in the pre-press print PDF through the APM&R website. So first and foremost, let's start with this. What's normal for the sagittal cervical curve? Well, number one, we have to have an X-ray, an MRI, or a CT to evaluate this, and it should be evaluated in upright standing position such that the X-ray is the easiest of those three to attain. So getting an upright MRI sometimes is not an option. Getting an upright CT is rarely, if ever, an option. And then the dosage with CT imaging is quite high compared to X-ray imaging. And then the limitations of MRI and upright stance can sometimes be an inhibitory factor as well. Although some of the newer advanced technology, you can get away with it. It's still easier to take a neutral lateral resting X-ray. So I'm going to say we should have a lateral cervical X-ray to identify what the state of your curve is. We know it should be a smooth geometric shape. It should be a uniform rate of curve such that each disc space from the bottom of the neck, called C7, to the top of the neck, C1, C2, contributes an approximate equal amount of curvature to the entire column. So shown here on the right is a uniform rate of curve, a smooth increasing cervical curvature where each segmental angle contributes almost the same amount to the total angle of curve. And then each disc space is roughly equivalent below the C2, C3 level. So we have nice healthy disc spaces at each level. We've got a nice angle of curvature at each level. And then the shape of the vertebrae are quite nice. They're not malformed and basically disfigured. If we look at this x-ray on the left, what you're going to see is this person has lost their curve. In fact, they have a reversal in the mid-cervical area, and then they have quite extensive degenerative disc disease and spinal arthritis. Now, part of this you can say is dietary and genetic. However, let's realize that if it's entirely genetic, then why is this level spared up here? Why does the C2 to C3 level look good? Well, we've talked about that previously in other investigations. We know that mechanical loading or alterations in the shape of the spine play a role in how fast and where your spine degenerates and gets disc disease and arthritis. Now, in the early phases, this person may very well have had a disc herniation. They may very well have had what we call arm pain and radiculopathy. These are the types of patients that we're studying in this clinical trial that I started with in the APM&R that just came out, or pre-press. Now, what we did is we took subjects that were in their mid-40 years of age, and we looked at those that had chronic neck pain, chronic unilateral arm pain due to a disc herniation. These subjects had to have radiculopathy, and they had to have true signs of nerve root involvement. We measured that with dermatomal somatosensory evoked potentials. We also looked at their neck disability index. We looked at their neck pain intensity in addition to their dermatomal somatosensory evoked potentials. And with an evoked potential, we're looking at how fast the nerve signal is, and we're looking at its strength of the signal, or what's called its amplitude. So those are our primary outcome measurements. Now, back to the question at hand, what is a normal cervical curve? Well, nobody knows the definitive answer for the perfect curve. What we do know is qualitatively it should be a uniform shape. It should have what I just called a uniform rate of curve, or a piece of a circle in its geometry. It should be somewhere between 20 and 40 degrees. If you look at the typical studies in the literature, that's what we see. It should be between 20 and 40 degrees. It depends on the population you're investigating. Now, what we did in this particular project is we sampled out a subgroup of patients with chronic neck pain, disc herniation, and arm pain, but those that had curves under 25 degrees. So when I look at the C2 to C7 angle of curvature, to be in this study, you had to have less than a 25-degree curvature. Most of the subjects, in fact, all of them were quite well under that. The average amount of curve was, in fact, about 6 to 7 degrees in the population that we looked at. Now, also, these subjects had to have forward head translation. Now, if you'll look here, the green line here on the abnormal shaped cervical curve, this shows where the back of the body of C2, this piece right here of cervical vertebra number 2, should be. The distance between those two, we can measure and classify that as forward displacement of the head and upper neck relative to the lower neck or upper thoracic region. So we call that anterior head translation. To be in our population, you had to have at least 15 millimeters of anterior head translation. So we have loss of the cervical curve defined as less than 25 degrees. The subjects were much less than that. And then we have subjects that have at least 15 millimeters of anterior head translation. The majority of subjects were quite larger displaced than that. So this is what we're looking at. Subjects that have a true confirmed disc herniation on MRI that's creating a shear load acting on the nerve root and the spinal cord. Now, specific to this project, we only chose subjects that had a C6 disc herniation. So we had the 6th and 7th classically nerve root involvement, right? Number one, this is the most common location. Number two, you have to isolate this out, because if I put C2 disc herniations in with C7 disc herniations, you don't really understand the mechanisms involved here. So we chose to narrow our population only to C6 nerve root level. Okay. Number two, this is truly a prospective, randomized clinical trial with a long-term follow-up. The trial was properly registered out of a database in Africa, and this randomized trial was performed at Cairo University. Okay, so this was done at the outpatient clinic department in Cairo, Egypt, in one of their hospitals there. We have 40 participants that met the inclusion criteria. We screened approximately 100 subjects to get these, right? So we have 13 females and 27 males. The patients are an average of the mid-40s, but they were allowed to be in the 4th and 5th decade of life, okay? They were randomly assigned in equal distribution groups to either a PT control group that did not receive the Denerol to rehabilitate the cervical curve, or a group that got PT and the cervical Denerol. So both groups got what we call the standard PT intervention program, which you will see, and it also included chiropractic style manipulations for the thoracic spine. I call it chiropractic style so I don't get any hate mail or hate messages. This was done by trained PTs in spinal manipulative therapy. And quite frankly, it's pretty much the same, but chiropractors like to, semanticize this out and say, well, when a chiropractor does it, it's a specific adjustment. When somebody else does it, it's spinal manipulation, whatever. You can call it an orange, and I'll call it an orange, by the way, just for fun. Randomized sample size was determined properly by statistical calculations. So we looked at what did we need to achieve statistical significance for the primary outcome measurements. And we needed a minimum of 15 subjects in each group. So to account for dropouts, we increased that by 5, and we got 20 subjects in each group, and we need a minimum of 15 at the end of the 1-year follow-up. Now, let's be realistic here. Number one, if you're a patient, not every single patient with a disc herniation has loss of their neck curve, okay? We don't know until we take an x-ray. Number two, not every single patient with a disc herniation and loss of their neck curve is going to respond to the type of care that we're going to be doing in this project. The reason is some disc herniations, when we try to put a curvature back into the neck, it can actually compromise the nervous system or the nerve root even more if we're not careful. So we always, as doctors, as healthcare providers, which chiropractors are licensed healthcare providers, and over in Egypt, these physical therapists, they are healthcare providers. We know how to screen people for an indication or contraindication to this intervention. If I'm going to put you on this cervical Denerol device that we're testing to improve the cervical curve, number one, I need to make sure you're a safe candidate for it. So if you bend your head backwards and you go, ah, and it lights up your arm with pain, you're not a candidate for this, right? We have to do other things. You have to do other things first before you can put this person on the cervical Denerol. So not everybody goes on the Denerol. So if you're a patient out there, patients go, well, I have a disc herniation, I have loss of my curve, I want to buy the Denerol. We don't do that. We don't sell the Denerol to patients because I don't know if you're a candidate for it. You don't know if you're a candidate for it. You're not a doctor. You don't want to do something wrong. So you need to be evaluated and screened, and that was part of our project. If you put your head backwards and you lay on the Denerol and it made your arm worse, you're not in this study. That's why we had to screen almost 100 subjects to get 40. The other thing is, if your arm is now weak, you're losing muscle mass, and your arm is atrophying on one side compared to the other side, if your strength is what we call greater reduced than a 4 out of 5. In other words, right here, if you are a 3 or less in your motor strength, then you are not a candidate for this. It means it's been there a long time, your muscles atrophying, and we actually need to send you out for a surgical evaluation. It doesn't mean you absolutely have to have surgery, but you may be a high-risk candidate for it. So if you can barely contract your muscle and you're noticing serious shrinkage on one side to the next in your forearm or your bicep, you need to immediately go and get a neurological evaluation and consider surgical consultation, because there is a window to where you have to take the pressure off the nerve for it to heal and for the muscle to come back. So keep in mind, we went through this entire screening process and said, okay, these are the high-risk cases. You're not a candidate for this project. You're not a high-risk case. You are a candidate for this project, okay? And then also we did Sperling's test. upper limb tension test, cervical distraction, and movements of the spine to see who was the primary candidate for what we were doing here. Additionally, in order to be in the project, you had to have a left or right side-to-side difference in your dermatomal somatosensory evoked potential of 50%. So we wanted true nerve root involvement. So if the amplitude of your left and right C6 median nerve was under 50% difference, you couldn't be in the study. We had to have at least 50% differences, which is an important thing. Exclusion criteria, many things. I already went through a couple of them. You bend your head backwards, you get arm pain. If you have motor loss more than a 3 out of 5 using standard tests, then you're not a candidate. If you're using narcotic drugs, you're not a candidate for this. If you have complete loss of sensation using brushing sensation or pinprick, you're not a candidate for this. And then if you have rheumatoid arthritis, other inflammatory disorders on anticoagulation medication, etc., you're not a candidate. So really what we wanted to do is have people with loss of the curve, forward head translation, disc herniation and arm pain, but you couldn't have severe motor loss and severe sensory loss. You would call it mild to moderate cases that we included in this. The patient demographics, I'm going to defer you to the APM&R study. You're going to have to read and download that figure. I'm just going through verbally kind of the abstract, adding a few more details to this. Suffice it to say, our patients were matched for the proper variables: age, weight, height, sex, pain. They all had chronic moderate pain intensity using numerical rating scales. They were between 5 and 6 out of 10 on the NRS. They had chronic mild to moderate neck disability index. So you can read the paper for that. This is what we did in the project. I got emailed a couple questions when I launched out the abstract from the APM&R website. People wanted to know, well, what does the multimodal program entail? Well, here's what we did, and you can get more details on exactly what we did by reading the full text paper. Both groups got this. Both groups got 10 weeks, 3 times a week, or 30 sessions of the following things: hot packs and TENS therapy to the cervical spine and upper thoracic spine. Both groups got seated and supine full thoracic manual manipulations. That's grade 5 manipulations, okay? Myofascial release to the upper extremity brachial plexus area and to the cervical spine. A functional exercise protocol using standardized techniques to train the deep neck flexors, training scapular retraction for what's classically called the upper cross syndrome. In PT and rehab literature, it simply means your head's forward, loss of the curve, and the shoulders are rounded. That's called upper cross syndrome in the rehab literature. I just call it forward head translation and rounding of the shoulders, but you can call it what you want, same thing. Okay, functional exercises to rehabilitate that. It's thought to be one of the things that's needed to change the shape of the cervical spine, posture, and position of the shoulder. So we're going to see, does that work? Serratus anterior activation using an anterior standing wall push-up. This is also associated with the upper cross syndrome, trying to rehabilitate and get activation in the serratus anterior so then it holds the scapula back in a proper position. Okay, we did these exercises every time the person came in, so 3 times a week for 10 weeks. They then did 3 sets of 12 repetitions for the majority of the exercises. Okay, so every time they came in, they did 3 sets of 12 repetitions, or 36 reps total of each of those things we just listed. Also, both groups got an at-home intervention. At home, they did neck retractions to pull the head straight backwards to correct the anterior head translation. They also scapular retracted for the upper cross syndrome as well. They did extension exercises, and they were required to record this on a daily log sheet. We had, as part of the study, we required that the subjects brought in their daily records once a week. And so the treating physical therapist at Cairo University or a research assistant tracked that and said, yep, you're doing it, or no, you're not. We had a great compliance, 95 to 98% compliance with the home care, both groups. Okay? So doctors out there, chiropractors out there, let me take a step back. People always go, well, I can't get my patients to do their home care. And I look at them, I go, really? Can you get your kids to eat your vegetable or eat their vegetables? I mean, it's the type of parenting you do. You know, you see the kids running around creating hell and they throw food all over and won't eat their vegetables, that's your fault. So when I look at this with patients, doctors say, well, patients won't do their home care. And I go, to me, it's the same as raising your kids. My patients actually do their home care. You can look at a patient and you go, you got two choices, right? Do you want to do your home care and not get get results, or do you not want to do your home care and not get results? Which one would you like to do? And patients go, well, man, if you put it that way, I'll do my home care. And you go, thank God, now I don't have to spank you like I do my kids when they won't eat their vegetables, right? Not that I'm spanking patients out there, but you get the idea. Doctors, you need to kind of reassess yourself and the way you do things when a patient won't comply. And then if you're a patient out there, just let me be direct with you. You've got to do the work. You've got to put in the time and effort. No doctor heals you. Healing comes from you within your body. If you don't put in the work, you don't get the results. The doctor is the coach. We do our job. You do your job. It's a team. Okay? We have to work together as a team. If that's too direct for you, then my apologies, but that's just the way it is, right? Okay, so this was done in both groups. Okay, both groups, including the home care. 3 times a week for 10 weeks, in the office, every day at home. And then the intervention group got one extra thing. They got the cervical dental device. The cervical dental device is what we believe is needed to change the cervical curve and the forward head posture. We believe, we don't know. That's why we're testing this. Now we're doing a bunch of things to both groups. They do a bunch of things, and then one group gets one therapy that's different, the dental. This way we can actually track what the dental really did. We can see what the difference is. We call this a multimodal program with the addition of one extra feature in one group. That way we can see what this extra feature does. Of interest, this is really what healthcare providers do with the average patient that comes in. We don't just do one thing and go, okay, let's see what that one thing does. We apply a host of different treatment methods thinking that that's going to be in the best interest of the patient. So we'll do stretching, we'll do exercises, we'll do manual manipulation or adjusting, we do some ice, we do some heat. So we do all these things in an effort to try to control the patient's pain and disability the best we can. So this is really what a clinician does in their practice. From a research perspective, we want to see what the addition of one extra device, the dental, does to this whole outcome pool. Now when we do that, here's our frame of mind. This is why we designed the study this way, so for doctors and for patients. The risk is I do all these things. I look at it, I go 1, 2, 3, 4, 5, 6 things are going on in terms of generalized treatment with people. 6 things. Both groups get these 6 things. I then add a 7th thing to one group. The risk is the 7th thing washes out in the noise. That's the risk. But you know what? I think that's the best way to design a study. Because if I only do 1 or 2 things in both groups, then I add an additional thing, I'm more likely going to see a response from this additional thing. That's the frame of thought. So we're designing this study to really find out, does the dental really do anything? Let's do everything that we know to do in both groups, and then we'll add one variable. So hopefully that explains our rationale and reasoning behind this. Maybe you don't agree with that, but that's the frame of mind that we had when we designed this study. So a few things that they were doing. The cervical dental, the large device is for taller, more flexible people that can actually bend backwards. The medium-sized device is for stiffer spines that don't have flexibility or shorter spines. Now, if you're a patient, you don't just get to buy this and use it on your own. This has to be under direct supervision of your healthcare provider to make sure, A, you are a candidate for it, B, it's placed in the proper location, and C, you're using it correctly. So when we get on the dental, the peak of the dental goes at the apex of the abnormality in the shape of the cervical curve. So if your cervical curve is mostly abnormal in the mid-cervical spine, then you're going to place the dental in the mid-cervical spine, the peak of the dental, as in this x-ray image of somebody lying on the dental here. Okay? Now, the majority of our subjects got the dental in the lower neck. Why? Well, they had lower neck disc herniations, C6, C7, nerve root involvement, and they had forward head translation, so placing it in the lower neck is really the most appropriate thing. 75% of the subjects got the dental in the lower neck. 25% of the subjects got the dental in the mid-cervical spine. Now, that's not because they had a mid-cervical spine disc herniation, that's because they had a mid-cervical spine reversal. So separate that out. All subjects had lower cervical disc herniations. However, the dental is placed based on the shape in the spine, not the location of the disc herniation. We start with 1 to 3 minutes per session on the dental, and then over 30 visits, we work the person up to where they do 15 to 20 minutes per session. Okay? Now, in the university, this was done under direct supervision of the therapist, and we have repeatability of placement of the dental. At home, patients have to be trained how to use the dental. So if I'm a chiropractor or a PT or an MD and I'm selling a dental or prescribing a dental to a patient at home, I must train them how to use this properly so the patient knows how to place it. And I must coach them on it. Now, in this trial, patients did not purchase a dental and use it at home. They only did it in the PT outpatient hospital at Cairo University. They did not do home care. They only did 30 sessions. Outcome measurements: X-ray, looking at cervical curve, looking at forward head translation. These are the doctor-driven outcomes. That's what the doctor wants to see. Did we correct the deformity we were working on? Okay, we also have, as a different project, not part of this project, a different project, did the shape and size of the disc herniation change over time? That's a different project. In this one, we looked at X-ray measurements, and then patient-relevant outcomes were the Neck Disability Index, arm pain and neck pain on the numerical rating scale from 0 to 10. 0 is absolutely no pain. 10 is severe, incapacitated pain. You're not even in here because you can't get in the clinic because you're in such bad pain. Patients, not to minimize, you sometimes want to be a 10. You can't be a 10 if you walked in the office. You can't be. 10 is incapacitated, you're carried in on a stretcher, and you're screaming in pain. That's a 10. So we're looking at people that were 5s and 6s out of 10, which is moderate intensity, pretty bad pain, right? Then we looked at physiological outcomes using latency and amplitude of dermatomal somatosensory evoked potentials using the median nerve. And also, as part of the study, we looked at spinal cord evoked potential using what's called N13 minus N20. Now, this is an important feature of the study. We wanted to look at the peak latencies of the major negative potential from the neck, N13, that's the bottom of the neck, and of the scalp potential, that's the skull, N20. These were measured with a cursor and a digital readout. The difference in the peak latency between N13 and N20 is what's called central conduction time or spinal cord conduction time. Then the dermatomal somatosensory evoked potential would be the difference, from the scalp to the tip of the finger, and then subtracting out the spinal cord evoked potential. So we can look at nerve root potential, speed, and amplitude, and then we can look at spinal cord N13 minus N20. This is the very important part of this project, to me, is looking at the spinal cord part of this, and I'll have some information on that coming up. Basically, how is your nervous system functioning, right? How is your nervous system affected by this loss of the curve and the disc herniation and the pain you're having? Now, results. At 10 weeks, both groups are better than when they started at the start of the study. However, there are no significant differences between the two groups with respect to the following things: arm pain and neck pain. Let's stop right there. Both groups feel better with their neck and arm pain, right? Why? Well, we did 30 visits of a bunch of things. So both groups feel better, neck and arm pain. They go, yeah, I feel better. However, the group that got the Denerol was no different than the group that did not get the Denerol in neck and arm pain, okay? So you might look at that and go, well, that's a bummer, right? Because now the patient that got the Denerol, an extra intervention, it looks like it didn't do anything for their neck and arm pain, at least at 10 weeks, 30 visits later, right? Latency outcomes. What are latency outcomes? Well, latency outcomes is the dermatomal somatosensory evoked potential, and latency is the speed. How fast is this signal in milliseconds? Okay? How fast is this? There's no difference in the latency outcomes. Both groups are actually somewhat better with the speed of transmission of the dermatomal somatosensory evoked potential. So if you just looked at those three variables, you would go, Denerol didn't do anything at 10 weeks. However, what we did notice is this. Of interest, the anterior head translation and cervical curve are statistically better in the Denerol group. How much better? Approximately 13 degrees and approximately 10 millimeters, if I remember correctly. It's funny that I don't remember. I've written so many damn studies. I don't have the number here, so you just go to the Archives of Physical Medicine paper, and you'll see it's 10 to 15 millimeters better in the Denerol group, somewhere in there, right? Done a lot of these projects, so the exact number escapes me. But it's statistically better, we'll say that. Then the amplitude of the evoked potential. The amplitude meaning the strength of the signal of interest. Even though the speed's no different between the groups, the power, the strength of that nerve impulse action potential is actually better in the Denerol group. The neck disability index is statistically better in the Denerol group. That's a big deal. The neck disability index is not just how much pain you have. It's what your limitations of activities of daily living are, right? It's a different type of assessment. Of interest, the neck disability index is better in the group that got the Denerol 30 visits later. And then here's the kicker. This is my favorite one. I go, whoa, N13 minus N20, what's that? Well, that's the spinal cord central conduction time. That is your spinal cord is working better or faster in its speed of transmission in the Denerol group. Wow. How do you explain that? Well, I'll try to explain it with a proposal at the end of the project here. Now, that's at 10 weeks, 30 visits. Now, what happened in this project, we stopped care at the end of 30 visits. Stop care, at least in the hospital setting. Okay? Then we follow them for another year. So they got 30 visits, stop care, we follow for another year. Then we reevaluate at the end of that year. So the whole length of the trial is 1 year and 10 weeks. 10 weeks of true treatment, stop, follow for a year. Both groups were allowed to do home care like they did in the first 10 weeks, but they did not do the Denerol. They didn't do the Denerol. They just did some of their exercises and things that we allowed them to do at home. We tracked that in both groups. There was no differences in the groups during home care at 1 year follow-up. But no subjects did the Denerol after 30 visits or 10 weeks. Here's what we found at 1 year follow-up. This is probably the most important part. 10-week outcomes, those are meaningful, but they don't mean lasting benefits. So 1 year outcomes, here they go. Significant differences between both groups for all the variables. What does that mean? That means all this stuff up here is now different between both groups. That means that the arm pain, neck pain, and latency outcomes in the group that did not get the Denerol, they start to get worse again. The Denerol group actually shows continued improvement such that at 1 year, there's strong statistical differences between the two groups favoring the group that got the Denerol. That means the arm pain, the neck pain, the latency, the spinal cord, the neck disability index are all better in the Denerol group at the 1 year outcomes compared to the group that only got the PT and spinal manipulative therapy. The control group pain and disability is thus regressing back to pre-study values, where they were when they started the study. The control group is now taking more medication. We tracked that. They're taking more medication than the Deneral group. This is a big deal. I mean, hey, you got to take drugs when you're in a crisis. They help with pain and disability. They cover it up, right? But do you want to continue to take those? I mean, what if there was an option for somebody to go, you know what, if we rehabilitate this, the chances are that you might be statistically more likely to be able to get off your medication at 1 year follow-up. And you'd have to go back to your MD and get reevaluated for that. Wouldn't you want to do that as a patient? I mean, that's just a direct question from me to you. Wouldn't you want to do that as a patient? I look at it and go, hell yes, I would, right? So rehabilitating the cervical curve with the Deneral, here's a sample 10-week follow-up, 30 visits later, and here's a sample 1 year later. Now this is not in the study. I'm not showing figures out of the study. I'm forcing you to go to the journal and purchase this full text if you want to read it and get more detail. I purchased it. I'm one of the authors. I'm the last author, the supervising member of the team, and I went to the archives of physical medicine, paid $35 and downloaded this study yesterday. Why? Because I value the work that much. I paid to get my own paper that I already wrote, already have a draft, and already read, by the way. And you could look that up, right? Just, to say thank you to the APM&R, $35. Now, why did the spinal cord evoked potential improved? Why did N13 minus N20 improve? What's the mechanism? Here's my proposal on this. Can I prove this? No, we can't prove it. We don't know 100%. But this is more than likely the way it works. This is the probability. Not possibility, probability. This is the way it works. It's more likely than not. When you lose your cervical curve, you put longitudinal stretch and strain on the central nervous system, brainstem, cerebellum. Okay? So this comes from Alf Bregg's paper in 1964 with him and Ahmed. And he and Ahmed, what they did is they looked at cadavers and they said, when you lose the cervical curve, you put stretch or tension on the spinal cord, brainstem, cranial nerves 5 through 12, and your cerebellum. Okay? For patients out there, this is the back of the skull. This is the front of the skull just before the jaw, and then the person's face would be up in here. This is the top of the neck. This is called C1. This is C2, C3, C4, C5. This is the spinal canal and spinal cord right there. You can see it's under stretch when you lose the cervical curve. Now, when you have a cervical curve, you'll notice that the spinal cord is relaxed slightly. It's under a relaxation. It doesn't have true stretch acting on it. Okay, now when you look at the microscopic level of this, here's the microscopic level. This is from Alf Bregg's 1978 textbook, Adverse Mechanical Tension in the Central Nervous System, 1978. Fascinating book. You need to look it up and purchase it. Really hard to come by. I've heard some estimates. Some people are picking this up for $500 to $1,000. I've got my own copy, by the way. I scanned this figure in and I'm showing it to you out of the book, right? I purchased that and I'm showing it to you. Now this is showing when you lose the cervical curve, look at the cells. This is a microscopic view. The cells are under linear tensile load. They're being stretched. When you have a cervical curve extension, the spinal cord cells are relaxed and wavy. Okay? You might think, oh, well, they're deformed. No, they're relaxed like a rubber band. It's like a bungee cord that's not under tension. It's relaxed. You know, the one on your left is stretched. This one is relaxed, okay? Now, what happens when you stretch a nerve? Well, a neuron, when it fires and we propagate an action potential down it, it's not just a chemical change. It's not just 1940s Hodgkin and Huxley sodium and potassium pump. Even though they won the Nobel Prize for it, it's wrong. 1940s. What we know today is the spinal cord or neuron, does this. We know it does what's called a phase transition. And it's as much as a mechanical event as it is a biochemical event. And it's not just sodium potassium, it has to do with calcium as well. This was shown at NIH by Professor Tasaki in the 80s and 90s, and then later research showed this too. It's amazing nobody knows about it, right? It's only been 30 to 40 years. The neuron shortens on its long axis. Shortens on its long axis. and then it swells in its cross-sectional area. Okay, that's what it's doing. It's called a phase transition. Okay, so it shortens and it swells. That's what it has to do along the full length of the axon as it carries a nerve impulse. Now, guess what a nerve probably can't do when it's under tension? If your nerve is under tension, your spinal cord, because you lose your curve, can it shorten and swell? Well, it can, but probably not as well. That's likely why when we restored the cervical curve with the Denerol, we showed that spinal cord evoked potentials are improving. In fact, what we found is this. The velocity of the evoked potential, the spinal cord evoked potential, increased by 23% by restoring the curve an average of 13 to 14 degrees. Was the evoked potential shut off? No, it wasn't shut off. But was it subtly impaired? Yeah, by 23%. You restore your curve, we found out an improvement in the spinal cord velocity of 23%. We found out the dermatomal somatosensory evoked potential improved by 24%. So this is the extrapolation part for me. You lose your curve, you put stretch and strain on your spinal cord. That is a type of subtle nerve interference. It impairs the physiological and biochemical mechanism of neurophysiological action potentials. And when you do that, there are consequences. Neck pain, disability, you name it, right? What are the other problems? What if this is what athletes are going through? Now, I know we only looked at disc herniations, but what if I take an athlete and they lose their cervical curve? Could they also have a 23% impairment in the speed of their evoked potential of their spinal cord and 24% in their nerve root? What would that mean to athletic performance? These are questions. These are things that need to be answered in the future. But wow, what a deal. You know, how else do you explain the improvement in these evoked potentials? Is it merely because of the disc herniation changing in size? I don't think so. I think it has to do with you're changing the stress and strain acting on the spinal cord by rehabilitating the cervical curve. That's the wow factor in the extrapolation of the study. This particular project, really important, shows that using the cervical Denerol as part of a rehabilitation program for people with neck pain, arm pain, and disc herniation, that improves short and long-term outcomes associated with the condition of disc herniations in a population that was selected to be included. Right? Keep that in mind. It's not for every single case out there. That's why it's called being a doctor. That's why we have to do an exam. That's why we have to do a proper evaluation and use our noggin and sit down and talk with people. Right? That's why we don't just say to the public, hey, buy the Denerol on Amazon.com and use it on your own. Potentially it's not right for you. Right? If you have this condition or another condition that you might want to consider getting proper care for, maybe you want to seek out a CBP-trained chiropractor. CBP-trained chiropractors know how to use and properly select people for the Denerol. They'll give you a proper evaluation. They'll tell you, are you a candidate or are you not a candidate, right? Many times we have to send a patient out and co-manage, and maybe you have to do surgical intervention. I mean, that's the other side of it. But maybe you are a candidate for this, and let's get your health back. Let's rehabilitate your spine and see how that does for you. Consider finding a CBP-trained chiropractor. Go to our website, cbppatient.com. Also consider supporting and funding our chiropractic biophysics nonprofit research department. In part, that's how we were able to help sponsor this particular study with Cairo University. And last and not least, or last and least, I do want to thank my colleagues at Cairo University in Egypt. They're just amazing. They're top-notch. PT, PhD, they're amazing professors, amazing people. They're an incredible research team. There's no way that I could have done this without them. And for me, this project is a dream come true. But realize it is a preliminary trial. We need to do more work on this, and we are continuing to do that. So hopefully you enjoyed this week's presentation. Until next time, I'm Dr. Deed Harrison. Thank you very much.